regarding the question from the Professor Yang, I think my interest is about the new adjuvant TKI targeted therapy is necessary if we already give the patients for the adjuvant targeted therapy for the early stage lung cancer, because from the data at this moment, we think if we give for example, the third generation osimertinib TKI treatment in the adjuvant setting, we already have very good DFS and OS benefit, HR lower than 0.2. So if we still give the patients TKI treatment before the surgery, could we significantly increase the survival benefit, or we have the comparable benefit? So always have this question. So I want to hear the comment from Professor Mitsudomi. Thank you.
Okay, thank you very much. I mean, so if you look at the neoadjuvant trials, the duration of the treatment before the surgery is far shorter compared to the after the surgery. Because although the post-operative adjuvant osimertinib is optional in that trial, but I think that most of the people will give the osimertinib after the surgery. So looking at the duration of the treatment, I think the effect of the post-3 of the osimertinib is greater, I guess. So you can shrink the tumors by giving the neoadjuvant treatment, but the effect of the long-term survival may not be very great. So I think if you compare the perioperative, so neoadjuvant surgery, adjuvant osimertinib with only adjuvant trial, I think that there will not be big difference. So this is very different in the case of the neoadjuvant immunochemotherapy. So that's my thoughts. That's my guess. How do you think?
Okay, thank you. Because I think the surgery after the TKI treatment will be more and more difficult. And if we cannot give better survival after the TKI new adjuvant therapy, I do not prefer to give the TKI before. Yeah. So
but sometimes if the tumors with ALK fusion is very big, then by shrinkage of the tumor by the neoadjuvant treatment may help performing the safer or easier surgery. So this could be possible, but the survival effect may be not so great.
Okay, thank you. Professor Yang, finish my question.
Okay, thank you. And I totally agree with Professor Mitsudomi that given the significant benefit with adjuvant TKIs, I don't think he can ever prove that the adding of 6 to 8 weeks of new adjuvant TKI could prolong survival. It's very, very difficult to prove that, because the most of benefit were from the 3 years of adjuvant TKIs. So the adding of 6 to 8 weeks will do nothing. You can never prove. Yeah, I totally agree. Thank you.
Thank you.
And our next discussant is Professor Chen Tianxiang from Shanghai Chest Hospital. Professor Chen?
Yes, I'm here. Thanks, Professor Yang's introduction, and thanks for Professor Mitsudomi's great presentation, and I learned a lot. I'm a surgeon from Shanghai Chest Hospital. I have actually we can call an old question. After Adora's funding, I was still questioned again by myself and by patient that is it time for us to abandon adjuvant chemotherapy for those patients with EGFR mutation who need adjuvant therapy. So in the daily practice, especially for those stage 1B patient, sometimes maybe I'm keen to use EGFR TKI for adjuvant therapy alone. But for those higher stage patient, maybe I will consulting those oncologists opinion, and most of them would like to do chemotherapy plus EGFR TKI. So I would like to ask Professor Mitsudomi's opinion about after patient gets surgery with EGFR TKI mutation. What's your opinion? Do they can we abandon chemotherapy for them?
Yeah, thank you very much. Very important questions. And I think that most of the patients with stage 3 are actually given chemotherapy in ADAURA. So about 80% of the patients with stage 3 receive the platinum doublet chemotherapy before randomization. So based on if you want to, based on the data of the ADAURA, so I think we should give the chemotherapy, especially for the stage 3 patients. And as I showed in my talk, that the DFS curve is better for the patients without chemotherapy because those patients are mainly stage 1B patients, so earlier disease. But if you look at the overall survival curve by the chemotherapy, then for example, 5-year overall survival of the osimertinib is 87% in the patient with chemotherapy and 88% without chemotherapy. So the difference are not present in the overall survival. So that may mean that could be attributable to the giving of chemotherapy. So for both reasons, I'd like to recommend to give the chemotherapy, especially for the patient with stage 3 disease.